My colleague Mike was just informing me that we might have some load shedding. So when that happens, we lose power for like a second before the generator picks up, just so that you are not surprised by that. But thank you everyone for being here and for choosing to be with us and spending your last 50 minutes in this room with us. You are more than welcome. We are talking about a very important topic about children that are in the epidemic. And my name is Mosarwa Sehwabe with USAID Botswana. I'm a Deputy Director in the Health Office and a Senior OVC Advisor. I have the pleasure of hosting this session and this wonderful panel of three. Two of whom are in the room right now, and our other colleague is joining us from Uganda online, Jennifer. So I'll go ahead and introduce them before I invite the first speaker to come to the podium and take us through their presentation. Again, the session is about evidence-based support to children and families in the epidemic. Our panel of three, the first one is Admas Terefe. Admas Terefe is the OVC Services Specialist from Integrated Service on Health and Development Organization, ISDHO, in Ethiopia. Admas is experienced in OVC, education, violence against children, gender-based violence, HIV, and research. He holds an MSc in demography, specializing in reproductive health. He holds a certificate in leadership and management in health and BA in economics. He has had several positions during his career, including child welfare manager, youth programs coordinator, OVC officer, and OVC services specialist. This evening, he will present on factors of age-appropriate services that influence virological suppression in children and adolescents with HIV. Ladies and gentlemen, Admas over here, but let me, yeah. Then our second panelist is Lisa Jamu. Lisa Jamu is the executive, can you wave to the people? She's the executive director for Stepping Stones International in Botswana. Lisa founded Stepping Stones International in 2006. She holds a master's degree in international development and health from American University and has 27 years of experience in behavior change and youth development. She will be presenting on stakeholder perspectives on conditions for implementing successful parenting interventions in Botswana and taking us through what works. And lastly, online we have Jennifer Okopa, joining us again from Ethiopia. She works for REPSI. She's the public health specialist with REPSI in Uganda. She has a master's in public health. She has over 18 years of experience in designing and implementing public health interventions. She has practical knowledge and experiences in designing and managing programs in maternal and child health, HIV/AIDS, sexual and reproductive health, gender-based violence, maternal health, education and child rights programming. She will be presenting on the role of smart peers towards penetrating female sex worker cohorts to include their children into HIV prevention and treatment program, and case of Asensero Health Center 3 in Koyatola district. So that's our panel. Let's give them a round of applause and thank them for taking the time to share their knowledge with us. To get us kick-started, Admas, please.
Thank you, Masarawa, for introducing me to the audience. My name is Admas Terefe Yasu. I'm from Ethiopia. My article is on factors of age-appropriate services. Factors of age-appropriate services that influence viral load suppression among children and adolescents living with HIV and with high viral load receiving ART. So I will take you through with these contents, I will touch a little about my organization. I will introduce you with Ishido. I will discuss with the background and methods of our study, and we will appreciate the results of our study or our article together, and I will share you the conclusions and recommendations that we suggested based on the results that we found. ISHDO was established in 1997 with the name ISABSO. It's mainly established to respond to the HIV epidemic when HIV AIDS was a killer and, or actually pandemic in Ethiopia. It changed its name in 2009 to extend its intervention or involvement in integrated development programs, including education, health, gender equality and inclusion, peace building, and conflict resolution. So ISHDO aspires to see healthy, productive, and self-reliant society in Ethiopia and beyond. This slide displays background and methods of our article, our study. According to the Ethiopian CDC and the Ethiopian Federal Ministry of Health, children are lagging in viral load suppression compared to adults. The country's performance of viral load suppression of children is around 90%, and that of adolescents is more than 97%. Children are behind because viral load suppression in children is affected by various factors, limited research are available that revealed the factors, particularly the service factors that favorably influence viral load suppression. So in order to mitigate this gap, or in order to fill this in order to narrow this knowledge gap, we conducted this study as part of the family-focused HIV prevention care and treatment program that we are implementing in 48 districts of the Oromia region of Ethiopia. The objective is to explore health and socioeconomic services that are favorably influencing viral load suppression in children and adolescents in the areas where we are implementing the program. When you see the methods, we followed 320 HIV-positive children who are virally unsuppressed for a minimum of 12 months from October 2020 to August 2022. Case management has done to identify adherence barriers, and care plans developed. Based on the care plans of individual child and primary caregiver, services communicated through referrals, and we provided various services from the program. When you see the data analysis, the methodology that we used the binary logistic regression model to determine the service factors associated with viral load suppression in adolescents and HIV-positive children with a confidence interval of 95. Okay. We used the binary logistic regression model to analyze the data with a confidence interval of 95% and a p-value of less than 0.05 to see the statistical significance. Yeah. This slide displays the results of our article. Before we interpret the output that we obtained from the SPSS software, we have tested the validity, appropriateness, and correctness of the model that we fitted with our data. The binary logistic regression model was statistically significant at a p-value, so we found that the model was significant, and the model correctly classified 95% 0.8% of the cases. That means the services that we are providing to HIV positive children and adolescents attribute to 95.8% of the viral load suppression among HIV positive children and adolescents, and the model explains 77.7% of the variance in viral load suppression due to the services that we provided. So the deep red columns indicate that these services, particularly early adherence counseling, SRH, VSLA, peer support group, and cash transfer, are correlated with viral load suppression. And the suppression we found that the suppression was efficient because the phi value is nearer to 1, which is 0.07. But the main finding is indicated under the blue column. As you can see, at the bottom you see the numerals, and at the top the percentages. The numerals are the odds of viral load suppression, and the percentages or proportions are the single effect of each of the services provided to HIV positive children or viral load suppression. That means for HIV positive children who have been linked to peer support group, the probability of being suppressed was 72%, SRH 57%, and enhanced adherence counseling 61%. In other words, the odds of viral load suppression of HIV positive children who accessed or participated in pediatric psychosocial support groups were 2.62 times higher than those do not have the access. So this is an incredible finding for us. All the services are statistically significant and clearly contribute to the viral load suppression of HIV positive children and adolescents. In conclusion, we believe that case management services provided at the community level can make a difference in achieving viral load suppression. Specifically, we provide only one recommendation. The first one is general recommendation, providing need-based, age-appropriate, and quality services without neglecting the coordination of community facility actors contribute to viral load suppression of HIV-positive children and adolescents, specifically peer support groups, particularly pediatric psychosocial support, enhanced adherence, and engaging caregivers of HIV-positive children in economic strengthening and SRH contribute to viral load suppression of HIV-positive children and adolescents. Thank you.
Thank you so much, Admas. Yeah, thank you very much. And again, we apologize for the power cut. We will work to catch up with time. The next presentation will be delivered by Lisa Jamu from Stepping Stones International.
They'll be making that bigger.
And as said earlier, her presentation is on stakeholder perspectives on conditions for implementing successful parenting interventions in Botswana and looking at what works. Over to you, Lisa.
Good afternoon. I love you, says Mama. I love you, says Mama. Mama, are you dying? Says the child. This is feedback that we got back from one of our sessions for Parenting for Lifelong Health. And this was because the mother had never told her teenage daughter that she loved her. We know that parenting programs have a positive effect. But one of the things that we weren't sure of is what are the stakeholder perspectives on conditions for implementing successful parenting interventions, particularly in Botswana? What works? Just to give you a little bit of background about Stepping Stones International, we're a non-governmental organization. We've been working in Botswana for 16 years, and our mission is to unlock the potential of young children and adolescents, ages 12 to 25, and we use holistic development. Part of that holistic development is strengthening families. And we believe strongly that you can't just work with the individual child, but that you actually have to work with the family, with the community, and at a policy level also, using the socio-ecological model. So why did we embark on this research? At the crux of society, we know that the family is the foundation unit. And the beginning of a child's development is in the family. Therefore, we must have programming in the family. We also know that violence against children remains a global problem with serious consequences. In most cases, violence occurs in the family setting. And in Botswana, there was a national survey done with including 8,000 adolescents that found 28.4% of females and 43% of males were victims of repeated physical violence, and the primary perpetrators were parents or relatives. So, as I mentioned, we know that parenting increases health, it increases school performance, mental health, social cohesion, and basically reduces the cycle of violence. And despite all this evidence, what we wanted to find out is what is it that creates an enabling environment for parenting programs to be successful in a country? So we formed partnerships with the Family Welfare Division, the Ministry of Local Government, and they were the co-investigators, along with the University of Cape Town and Oxford, who were the lead researchers with us. And we joined the International Super Study that Scale Up Parenting and Evaluation Research. And part of the Super Study, which is still ongoing for the quantitative side, is the qualitative baseline study. The methodology was that we interviewed 17 people in 13 different organizations, and including in that group of people was the Department of Social Protection, 2 UN agencies, and 10 NGOs. And we based the work that we did on a framework called EPIS. It's exploration, preparation, implementation, and sustainment. So looking at all of those factors. Here is what we found. It's not rocket science, but what it is this combination is really critical for your parenting program to be successful. The first one were enabling factors, and this just means family policies. What family policies are there in the country? What guidelines are in place? And how much government support is there? The second one is harmonization of donor programs. There are a lot of different donors, the policymakers, and also the implementing partners. So working together to decide what is the best parenting program for the country. I know for us, we've implemented 4 different parenting programs, and there are about 5 or 6 going on in Botswana. So it's really harmonizing the programs. The next one component is the stakeholder engagement. And this really goes to working with your beneficiaries to ensure that they are helping to design the program and that the community is involved in that design. Even though it's an evidence-based program, you still need to be able to adapt it, which is the next component, is program adaptation. And making sure that, for example, in Botswana, we're using Parenting for Lifelong Health. And what we've done is we involve the stakeholders, the beneficiaries, to put scenarios that really happen in the family in that curriculum. The next one is local empowerment, and this is ensuring that those who are facilitating the parenting program have ownership of it, and that you're pulling facilitators from the community and training them in how to implement, because they're the ones who understand the context the best. And then the next one is the mixed approach. So this is, while you can target the whole population and you want to use radio, for example, you might use television in certain cases, what you need to do is to be able to decide, okay, how am I going to target my parenting program? In Botswana, 73% of the households are single-headed households. So how are we going to really target those women or those men who are heading their households versus another type of family who are, both parents are there? For the next one, collaboration, I just want to read you a quote from our research. Organizations need to work together and share lessons and resources such as assessment tools. Platforms need to be provided for implementers and stakeholders to meet regularly. So it's about consistently and constantly sharing the process of how we're implementing the parenting programs. What are the challenges? How can we solve those challenges together and not as individuals? And then the staff support, that one is just meaning really training your staff, making sure that you're coaching them so that you don't lose the fidelity of the program, and that you're also providing mental health support because they do hear a lot of issues that are coming out of the families. And the evidence-informed interventions, that's basically using what we always say is really making sure we're using evidence-based programs, but that we're also monitoring them continuously. So it's an ongoing learning process. And the last one is human and financial resources. And that lends to making sure that they're in our national budgets. The implementing partners have enough money to implement the parenting program, but that it is embedded in the for example, for Botswana, in the district budgets and in the national budget to include parenting programs and training for social workers to implement. So our program in Botswana is Parenting for Lifelong Health, and we have coined it Pinahari, which is the pole in the middle of the hut that holds up the hut or the house. And so what we did is we looked at are we following our own components that came out of the research? And we found that under program adaptation, we scored high. We've adapted to the Botswana context. We had the stakeholders involved. We had the ministry involved, implementing partners. We even changed the name. A lot of people are still using, my colleagues using Sinovoyo still, but we made it Botswana. Evidence-informed interventions, not only are we using an evidence-based program, but we also are part of the larger super study in about 19 countries, and we are continuing to monitor our own programming and provide feedback on lessons learned. The stakeholder engagement, we're working with the Ministry of Local Government, and we're also working with the districts. We're trying to make sure that we train the social workers. We're not quite there yet, but it's a progress. Mixed approaches, we've infused it in dreams. We've also infused it, used another mixed approach. We produced a docudrama called Detunya Saruna, and that is Our Flowers. So it's a film with expert opinions, but it's really based on live scenarios of families with proper actors from Botswana. And that we use as a platform, a springboard for dialogue discussions that complement the Pinahari program. Local empowerment, we have recruited and we train our staff in whichever district we're working so that they really do understand the context and can relate to the parents. And we now are trying, we're not there again yet, to train social workers. And finally, for staff support, we are intensifying our training. We work with Clowns Without Borders to coach, and we're being coached by them. And now we are trainers in Botswana, so now we're able to spread that out to other implementing partners. And finally, for our collaboration, as I mentioned, we're working with the Ministry of Local Government and other implementing partners. This does have relevance for OVC and our gender-based violence in that the curriculum is PEPFAR aligned. It includes sexual reproductive health rights topics, such as understanding healthy and unhealthy relationships, sexual consent and disclosure, and of course, making decisions about sex. We have seen progress with this program. It's easier to implement than other programs that we've implemented, and we've actually seen lower abuse. And I'll just leave you, we started with I love you, but I was in Letlakani 2 days ago, and the mother got up as a testimonial and said, this program has really helped me. I used to drink at the Shebeen all the time, and now I know I'm leaving my children in an unsafe environment, so now I'm bringing my alcohol home. Which is a step. It's a start, right? But at least there is a baby start. But where we see the most improvement is budgeting. Parents and children are budgeting together so that they really understand how they can be more economically viable as a family. Thank you.
Thank you so much, Lisa. Thank you so much for bringing up the topic on parenting, which I don't think it has really come up during the week. So thank you for that. At this point, we will take our last presenter. So if you have any questions, please just keep them. We'll take them at the end. Our colleague Jennifer Okopa joining us from Uganda virtually, and she will take us through her presentation on the roles of Smart Peers towards penetrating female sex worker cohorts to include their children into HIV prevention and treatment program, the case of Kasensero Health Center 3, Koyotera District. Over to you, Jennifer.
Good afternoon, good evening from wherever you are. I'm Jennifer Opoka, presenting the role of Smart Peers towards penetrating female sex workers cohort to their children into HIV programs. So I just wanted to highlight that for this program, it's being implemented in one of the fishing landing sites in Uganda, a place called Kasensero Health Center in Koyotera District. So when we started this program in 2020, we realized that one of the groups that we could focus on are children of female sex workers. And this program is currently being funded by USAID, the Keeping Children Healthy and Safe activity. It's a 5-year project with its prime as TPO Uganda, and REPSI Uganda is a co-implementer. We are implementing five districts of. Sorry, my internet is a bit unstable. The activity focuses on
Oh, we lost her.